تفضل.
السلام عليكم. First of all, we want to thank Dr. Olf for joining us in this lecture. Today, inshallah, we will talk about ascending aortic aneurysm. I will talk about the surgical anatomy, the pathophysiology, clinical presentation, how to diagnose, and the operative technique. Dr. Olf, inshallah, will talk about it. So let's start with the aneurysm. Aneurysm is a permanent localized dilatation of an artery by at least 50% compared to the normal. So if we can see the normal anatomical location with this diagram, number one, as we see the aortic sinus of Valsalva, and number two, the sinotubular junction, and mid-ascending and proximal aortic arch, mid-aortic arch, then the proximal descending and mid-descending, and the aorta at the diaphragm, and lastly, the abdominal aorta. Talking about the normal adult diameter, so we can see the thoracic aorta, the root in female is ranging from 3.5 to 3.7, assessment done by CT. In male, 3.6 to 3.9. The ascending in male and female is equal, which accounting or ranging in 2.86. And this is the mid-descending in both male and female. Concerning the classification of the aortic aneurysm, it was classified in different way. The first one was true or false or pseudoaneurysm, then classification by location and by the shape, and by the complicating pathology. So regarding the true aneurysm, it's involve all the layers of the arterial wall. As we know that the arterial wall layers compose of three layers, the adventitia, intima, and media. Regarding the pseudoaneurysm, it's involve only the outer wall, consisting of the adventitia and organized thrombus, which is surrounding the structure. Regarding the classification by location, either ascending, arch, or descending, or abdominal by Crawford classification, as you see in the picture. By the shape is fusiform or saccular. Mainly the saccular aneurysm due to ulcer. And regarding the pathology, either ruptured or dissected. So this is the shape of the aneurysm. This is the saccular aneurysm, and the fusiform and the ruptured aneurysm. So just a brief talk about the surgical anatomy, because already mentioned before the anatomy of the aorta and the aortic root. The aortic root may be defined as a portion of left ventricular outflow tract, which is supported the leaflet of the aortic valve, delineated by superiorly the sinotubular ridge and inferiorly by the base of the valve leaflets. And its component include the aortic valve cusp, sinus of Valsalva, aortic annulus, and subcommissural triangle, including the sinotubular junction. The aortic valve cusp attached to the aortic annulus at like a hinge point following a semilunar contour, being a 3-point, as we know, crown type arrangement. And the annular tissue around the annulus, which is fibrous tissue along the hinge point between the aortic and the mitral valve, as well as the membranous parts, while the remainder is muscular. Small projection is of collagen that is anchored the aortic root to the ventricular muscle. As we know, the pieces of attachment of the cusp, known as the commissures, and the most superior aspect of the commissure interrelate with the sinotubular junction. The sinotubular junction is a ridge that marks the beginning of the ascending aorta. And between the sinotubular junction and the aortic annulus, are expanded segment of the aorta referred as sinuses of Valsalva. Each sinus is named for the corresponding coronary artery, right, left, and non-coronary. The non-coronary sinus is anatomically related to the left and right atria, as well as the transverse sinus of the pericardium. The left coronary sinus related to the left atrium, and the right coronary sinus related to the right atrium and right ventricle. So once there is a bleeding or rupture, it will be in the right atrium or right ventricle. The subcommissural triangle between right and non-coronary arteries anatomically related to the conduction system within the membranous septum, as well as the septal leaflet of the tricuspid valve. The left and the non-coronary subcommissure related to the anterior leaflet of the mitral valve. So lastly, the ascending aorta started at the level of sinutubular junction and ascend to the level of the takeoff of the innominate artery. Now let's talk about the pathophysiology. As we know, or as I mentioned, that there is a three-layer structure composed of smooth intimal layer, medial layer, and outer adventitia. The ascending aortic aneurysm formation is the result of several biological and mechanical mechanisms. So let's start with the biological mechanism, which is there is a disruption of the balance between the homeostatic mechanism with the aortic wall in form of the elastine and the elastic recoil, which cause the spectrum of as final pathway with aortic enlargement and eventually leading to rupture or dissection. The fragmentation of the aortic media necessary for the normal hemostasis include maintenance of dynamic integrity of the extracellular structure within the arteries. The aneurysm form as elastic layer fragments, smooth muscle become dysfunction and eventually elastic, and the smooth muscle component are replaced with cystic appearing mucoid material. So it will lose the elastic recoil of the vessel. The mechanical changes to the aortic wall characterize such as alternation in the symmetry, the compliance, and the stress-strain relation likely predate the dilatation. So change in the compliance broadly defined as change in the volume of the vessel with a change in the pressure lead to increased stress applied to the aortic wall during the systolic impulse and further exacerbate the biological derangement leading to the eventually the aneurysmal formation. So if we can conclude it or have a specific etiology, the first one is annulo-aortic ectasia and genetic connective tissue disease, atherosclerosis and dissection, valve malformation and infection, arthritis, trauma, and pseudoaneurysm. The first one, which is composed of ascending aortic aneurysm with the dilatation of the Valsalva sinuses and the aortic annulus. It can be occur as isolated condition or can occur as an a part of generalized connective tissue disorder, like in Marfan syndrome, which is a genetic disorder affecting the fibrin synthesis, and the elastine being basic component of elastic fiber, which will affect the medial layer. Exactly. The aorta in the Marfan exhibit a typical feature of cystic medial degeneration, which we talk about it in the pathophysiology. And about 85% have an aortic dilatation with or without aortic regurg. Another syndrome is Danlos syndrome, another genetic syndrome causes spontaneous arterial rupture, particularly in mesenteric artery, and it's associated with fatal outcome with the ascending aortic rupture. Isolated sinuses of Valsalva can occur rare abnormality caused by either congenital defect in the continuity of the medial layer of the affected sinus, and less commonly as acquired as in cases of endocarditis, syphilitis, or TB, or focal dissection. Atherosclerosis and dissection, the process in the aortic media cause extensive disruption of the elastic fiber and the smooth muscle cell, which may rather replaced by extracellular matrix and lipid. And there is a various invasion of the atheroma developed, and progression, it will lead to destruction and weakness of the aortic wall. Aneurysmal dilatation of the ascending aorta can develop second in patients who have who survive from acute dissection. And such aneurysm most evolve from a false lumen of the dissected aorta and have a greater tendency to expand and to rupture eventually. Valve malformation and infection, usually associated with bicuspid aortic valve, and a sequelae of post-stenotic dilatation, aneurysmal formation will occur in patients with bicuspid valve. And the aortic wall in the bicuspid valve disease patients show an increase in elastin fragment and fibrin deficiency and matrix disruption and the smooth muscle apoptosis. Aneurysm of ascending aorta, or what's called or referred to mycotic aneurysm, is rare, most commonly seen after episode of valvular endocarditis. Syphilis was the most common cause of mycotic aneurysm of the ascending aorta, but is rarely seen now. Syphilitic infection initiate the aortitis and obliterate the endarteritis, followed by destruction of vasa vasorum and degeneration of the medial elastic fibers. Arthritis, trauma, and pseudoaneurysm, systematic arthritis like in Takayasu or Kawasaki or Bassett disease, or giant cell arthritis, this is a part of vasculitis, involve the ascending aorta or initiate the information of aneurysm. Inflammation process in the medial layer, all about the medial layer and destruction of the elastin and elastic recoil, which will weakness and will lead to aneurysmal formation and eventually dissection. Chronic trauma, which is rare. Blunt chest trauma, most commonly involving the descending rather than the ascending. And patients with acute ascending aortic injury have very low survival due to development of tamponading and associated cardiac injuries. Pseudoaneurysm, which is not involving all the layers, may develop after trauma or surgical intervention or infection. Usually the post-op pseudoaneurysm may develop at site of cannulation or sutures line of the ascending aorta. So move to the, this is so the pathophysiology. Now talking about the clinical presentation. So the symptoms mostly or usually are asymptomatic and diagnosed incidentally, usually in chest X-ray or echocardiography. Anterior chest pain is the most frequent symptoms if it's appearing. The pain usually or maybe acute in onset and signify impending rupture or annoying pain from a compression of the underlying structure. Occasionally sign of SVC or airway compression may be present. Hoarseness due to stretch of the left recurrent laryngeal nerve, mostly the aneurysm is involving the descending rather than the ascending. Less commonly, the aneurysm of the ascending aorta or aortic root can rupture into a right atrium or SVC, presenting with high output cardiac failure or bleeding into the lung and eventually hematemesis. Acute dissection of the ascending aorta present with severe tearing pain greater than 75%. Physical examination, unremarkable. Signs of aortic rigor like widening pulse or diastolic murmur. Although the vascular exam should be carried out to look for a concomitant peripheral vascular disease, carotid disease or abdominal aortic aneurysm. Abdominal aortic aneurysm can be present in 20% in patients involved with the ascending aortic aneurysm. Diagnostic strategies: chest X-ray, ACG, echo, CT, and MRI. Chest X-ray, we can see that on the right side, absence of retrosternal airspace, and we can see the convexity of the heart, of the contour of the heart on the right side, on the left X-ray. This is a TEE showing the dilatation of the aortic root. This is a CT angio, also showing the dilatation of the aortic root. And this is also the three-dimensional imaging showing also the dilatation of the aortic root. Recommendation for screening: class 1, when the aortic aneurysm is identified at any location, assessment of the entire aorta and aortic valve is recommended as a baseline and during the follow-up. Class 2A, in cases of aneurysm of abdominal aorta, duplex ultrasound for screening of peripheral artery disease and peripheral aneurysm should be considered. Class 2A, patients with aortic aneurysm are at increased risk of cardiovascular disease. General principle, cardiovascular prevention should be considered. So, recommendation for medical management from the American Association: class 1, beta-adrenergic blocking should be administered to all patients with Marfan syndrome to reduce the rate of the aortic dilatation, unless contraindicated. Class 2A, for patients with thoracic aortic aneurysm, it is reasonable to reduce blood pressure with beta blockers or ACE inhibitors or Arabs to lower the point patient can tolerate without adverse effect. Arab, like losartan, is reasonable for patients with Marfan to reduce the rate of aortic dilatation unless contraindicated. Recommendation for asymptomatic patient: class 1, asymptomatic patient with degenerative thoracic aneurysm or chronic dissection or intramural hematoma or penetrating atherosclerotic ulcer or mycotic aneurysm or pseudoaneurysm who are otherwise suitable candidate and for whom the ascending aorta or aortic sinus is 5.5, they should be evaluated for surgical repair. And we will see the diagram for the approach in such patient with degenerative disorder. Patient with genetic disorder, like Marfan, should be undergo elective operation at smaller diameter, 4 to 5, depending on the condition to avoid the acute dissection or rupture. Patient with growth rate of more than 0.5 per year in aorta less than 5.5 should be considered for operation. Patient undergoing aortic valve repair or replacement and who have an ascending aorta or aortic root greater than 4.5 should be considered for concomitant repair of the root or replacement of the ascending aorta. Class 2A, for elective aortic replacement, reasonable for patient with Marfan or bicusp aortic valve when ratio of maximal ascending aortic root and divided by the patient exceeding 10. It is reasonable for patient with other genetic disorder undergo aortic repair when the aortic diameter reach 4.2 centimeter or greater by T up to 4.6 or by CT of 4.4 or 4.6 by CT or MRI. So this approach for ascending aortic aneurysm and degenerative disease: step 1, to determine the urgent for repair and the indication for urgent aortic operative management: size more than 5.5, growth rate more than 0.5 per year, and symptomatic. If yes, pre-op assessment to see if it's suitable candidate or no. If no, risk modification. If yes, we will do diagnostic imaging to identify coexistent pathology. And regarding this approach, we'll complete it here. We are doing the imaging to see the coexistent coronary artery disease. If no, we will do aneurysmal repair. If yes, we will do valve or CABG procedure plus aneurysmal repair. If no patient is not have no indication for urgent operative repair, so we'll do diagnostic imaging to evaluate for coronary or valvular disease. If yes, we will go for valve or CABG procedure plus aneurysmal repair if more than 4.5. If no, we will size adjusted disease surveillance to see if the aneurysm reaching up to 4.4 annually by CT or MRI, and to see the previous indication for urgent surgery. If yes, we will do the same preoperative assessment and coronary artery disease and pathology of the valvular disease, and we will manage accordingly. Ascending aneurysm in genetic disorder, the first step will determine the need for operative repair and the indication. The operative management size 4.4 till 5, and the patient is symptomatic. If yes, we will go for preoperative assessment, and we will go for, if it is suitable, we will go for diagnosis imaging for coexisting pathology, other valvular pathology, and other coronary artery disease. If yes, we'll go for CABG and or valvular procedure plus aneurysm repair. If no, there is no coronary artery disease or valvular disorder, we'll go directly for aneurysmal repair. If the patient didn't meet the criteria for indication of surgery, we'll do diagnostic imaging for coexisting valvular or coronary artery disease. If yes, we'll go for CABG or valve plus aneurysm repair of 4.5. If no, we will do surveillance annually by CT or MRI, and we will follow the same approach. Indication for surgery, we'll start with non-elective indication. Any new chest pain of acute dissection or rupture or intramural hematoma warrant immediate surgery. Presence of symptoms of chest pain in patient with ascending aortic aneurysm greater than 4.5 to 5 is a sign of impending rupture. It should be managed operatively with expediency. Acute severe congestive heart failure secondary to root dilatation and loss of siniotubular junction definition either from rapid aneurysm expansion or chronic dissection also warrant early operative management. Although aggressive diuresis and cardiac optimization for 1 to 2 days before surgery is helpful. Elective indication, despite the limitation of the size criteria, decision to intervene are still largely decided based on maximum aortic diameter and the growth rate. For a degenerative aneurysm, in absence of connective tissue diseases or other cardiac pathology, elective repair is reasonable at an absolute maximum diameter of 5.5, with a growth rate greater than 1 centimeter per year. The aortic ratio is calculated, measured diameter divided by predicted diameter for a given body surface area. And using this method, elective replacement is warranted at a ratio of 1.5 in asymptomatic patient without a connective tissue disorder or other complicating factors. This leads to intervention at size only up to 5 in adult less than 40 years with a body surface area of 2. In a specific consideration, like in genetic disorder, Marfan, they are at high risk of rupture, and the ascending aorta should be replaced prophylactically at the diameter of 4.5 or the aortic root 1.3 to 1.4. In patients with bicuspid, currently consensus is that the aorta greater than 4.5 or the aortic root up to 1.4 should be replaced at time of replacement. In context of well-functioning bicuspid valve, the ascending aorta should be replaced at maximum dimension of 5 centimeters. In chronic aortic dissection, in which the external is supported only by the residual outer third of medial and adventitial layer, replacement should be performed with diameter 4.5 or ratio up to 1.4 because of the weakness of the aortic wall. In setting of connective tissue disorder or bicuspid aortic valve with a growth rate 0.5 should warrant the repair. In pseudoaneurysm, which are frequently from the previous aortic suture line, should be repaired or diagnosed, be repaired on diagnosis because of high risk of rupture. In the setting of other cardiac surgery, ascending aorta with a maximum dimension of 5, with a ratio of aortic root dimension 1.5 should be replaced. So this conclude or the summary of recommendation of ascending surgery in aortic aneurysm. Class 1, the surgery is indicated in patient with aortic root aneurysm with a maximum diameter more than 50 millimeter for patient with Marfan. And the class 2A should be considered in patient who have aortic root aneurysm with maximum aortic diameter more than 45 millimeter in patient with Marfan with a risk factor, more than 50 in patient with bicuspid valve, and more than 55 in other patient with no else pathology. In preoperative consideration, we have to do the coronary angio. If a significant coronary artery disease is present, it is bypassed at the time of the aneurysm resection. Severe carotid disease is a risk factor for stroke, and during ascending aortic operation, patient greater than 65 should have a duplex for their carotids. Pulmonary status should be optimized before surgery because of concomitant chronic obstructive pulmonary diseases. Renal function also should be optimized. This is an algorithm approach to decision-making in ascending aortic aneurysm, a systematic approach to evaluate the aorta and aortic root begin with determining if there is a suspicious for a connective tissue disorder. So a patient, for example, with Marfan or bicuspid valve-related aortopathy or strong family history of an aortic dissection or rupture should generally be treated more aggressively by replacing the sinus segment and the ascending aorta and proximal arch, because of late reintervention is more likely in this group. The next step is to determine the pathology of the aortic valve. Moderate or severe aortic stenosis with or without insufficiency generally require a replacement, whereas the management of pure aortic insufficiency is more complex. Aortic insufficiency caused slowly by dilatation of sinotubular junction, typically from the aortic aneurysm in elderly patient, may be fully addressed with tube graft replacement of the ascending aorta along with anastomosis with the sinotubular junction. Patients whom have an isolated dilatation for non-coronary sinus and degenerative disease with brasive dimension in the coronary sinus. The non-coronary sinus may be individualized excise, and tongue of the ascending graft may be used to reconstruct these sinuses with the rest of the graft anastomosed above with a native annulus. So in patients in whom the aortic valve need to be replaced, the sinus segment is not aneurysmal, and there is an ascending aneurysm. Modified Wheat procedure with replacement of the aortic valve and placement tube graft is to the sinotubular junction is used. We will see in the operative technique. Regarding the natural history, the thoracic aortic aneurysm have a 5-year survival of about 40% compared to 20% thoraco-abdominal. 5-year survival for chronic dissection as low as 13%. Thoracic aneurysm increase in size about 0.4, this is the growth rate per year. Large aneurysm more than 6 expand faster than the smaller aneurysm for sure. The median size rupture or dissection is 5.9 to 6.9 for descending. and 5.9 for the ascending. Once the symptom develop, the mean time for rupture is about 2 years, with a growth rate of the aortic aneurysm less than 4 centimeters are about 0.1% per year. And this increases gradually when the aortic increase about 0.4 per year. The annual risk of rupture and dissection or death is 5 to 6 for ascending aneurysm and 10 to 15% for descending aneurysm. Regarding the mortality and for elective operation, 1 to 5% for elective repair of the ascending and 85% survival rate. 5 to 10% with repair of the arch, and 5 to 10% up to 60% 5-year survivor in descending, and to the same thing with the thoracoabdominal. Mode of death is rupture for sure, up to 70%, dissection, cerebral embolism, and visceral embolism. Before talking about the operative technique, I will talk about the complication. The early complication, bleeding and stroke, embolization usually from the debris or thrombus from the ascending aorta and arch, which can produce a focal neurological deficit. Diffuse injury can attribute it to micro emboli or air or cellular debris, which is usually from insufficient or uneven cooling or prolonged circulatory arrest. After circulatory arrest period exceeding 40 minutes, the incidence of stroke is greatly increased. Pulmonary dysfunction, cardiopulmonary bypass is known to cause the alternation in pulmonary function. Treatment usually is suppurative, and about 18% of patients require prolonged mechanical ventilation. Myocardial dysfunction reported in 2.5%, may be related to technical problem with coronary reimplantation. Perioperative mortality, the most common cause of early death are cardiac failure, stroke, bleeding, and pulmonary insufficiency. Emergent operation after the onset of acute dissection or rupture is high risk for early death. And the risk following elective procedure is increased by increased age, prolonged cardiopulmonary bypass, dissection, previous cardiac surgery, and need for concomitant coronary revascularization. Late complication. The late mortality is the most common cause of death of late mortality is cardiac, but distal aortic disease account for 32% of late death in one series. Reoperation occur because of pseudoaneurysm formation, or valve thrombosis, or endocarditis, or graft infection, or progression of disease in the native valve, or remaining aortic segment. Reported mortality is up to 22%. Up to 60% of reoperation occur because inadequate repair during the initial operation. Complication related to residual thoracic aorta and arrhythmia. And the most common late complication was the thromboembolism. The last one for the late complication is the graft infection, which is ranging from 0.9 to 6% following surgery of the thoracic aorta and associated with very high mortality, up to 75%. The major bugs were the Staph aureus, Staph epidermidis, and Pseudomonas. Patient frequently present with persistent fever and elevate WBC. CT or MRI demonstrate an air or fluid collection around the graft, and maybe there is an associated pseudoaneurysm or fistula or anastomotic leak. TEE can show valvular vegetation or abscess. Treatment ideally is IV antibiotics and cultures. Surgical management for the infective graft, removal of the infective prosthetic material, aggressive tissue debridement, local irrigation, systematic antibiotics, and replacement of the conduit, and use of the autologous tissue to surround the graft and obliterate the dead space. Usually the greater omentum may also be brought up as a vascularized pedicle to wrap around the aortic graft and isolate it from the sternum if it is infected. Like in concomitant sternal infection, should be managed with aggressive debridement and sterilization with vac and delay flap reconstruction. So this is about the brief about the pathophysiology and how to diagnose and clinical presentation and some guidelines. Now we'll talk about operative techniques. Dr. Olf, he will start now.
So when you speak to this,
Yeah, you can speak. Yeah, you can speak.
everyone can hear me, do you think?
Yeah, yeah.
Do we? Okay. Hello, everybody. I hope,
Hello, doctor. Yes.
I hope you're all healthy.
Alhamdulillah.
Yeah. So I will briefly talk about surgical technique for elective surgery for the ascending aorta aneurysm. And if we start with cardiopulmonary bypass technique, perfusion technique, everything is of course depending on the pathology that we have in front of us, what we need to address, and how big the aneurysm is. I mean, in terms of length, does it involve the arch or not? Does it involve the aortic root, the aortic valve? So depending on the findings, you can go for, it's mentioned here in the slide, axillary cannulation. I never address the axillary artery. I always go for the subclavian artery, the right side. And sometimes, of course, femoral cannulation. If you just have a sole aneurysm, no dissection, you can go for both techniques. It doesn't matter actually if you have a retrograde perfusion or if you have an antegrade perfusion. If you have a sole ascending aorta aneurysm that not involve the arch, you can of course cannulate the arch. The drawback is though that you have the cannula in the operative field that might disturb you, but this is of course possible. If you believe you need to, I need to mention first of all that these slides are not mine. So I disagree in some of the statements in these slides, but never mind. So if we have an aneurysm that involves the arch, you need usually to go into circulatory arrest. If the aneurysm involves the neck vessels, you usually need to go into deep hypothermia because the procedure will take, or the surgical procedure technique will be prolonged, and the time of circulatory arrest will be prolonged. So usually we cool down the patient to 18 degrees, and reaching 80 degrees, we can turn off the cardiopulmonary bypass, open the aorta, and then resect the aneurysm. If the aneurysm is not involving the neck vessels, you usually can go for a so-called hemiarch That means that you don't touch the neck vessels, you leave them in a cuff, and you anastomose the cuff to the tube graft. And that is quite a quick procedure, so you don't need to use any cerebral perfusion for this short procedure. However, if you need to address the neck vessels, it's usually it's a prolonged procedure, as I mentioned, and you need to be able to perfuse the brain, even if you have cooled down the patient to 18 degrees. So you can then either use the retrograde technique, you go with an extra arterial line to the SVC, you snare the SVC and you perfuse the brain retrogradely. The advantage doing this is that you have a washout from the neck vessels, and the risk of having debris that is embolizing is maybe less. This is my personal opinion. There are definitely surgeons who object to use retrograde cerebral perfusion at all. They prefer antegrade cerebral perfusion, selective. You perfuse every or all three of the neck vessels separately during the procedure. So circulatory arrest should, of course, be as short as possible, because the risk of having cerebral injuries are increasing by time. So usually 40 minutes in temperature of 18 degrees is usually the cut off that you need to be below. So what's next? I think we have. So what kind of techniques do we use for these kind of aneurysms? It's also depending, of course, of the preoperative findings, the pathology. Is the valve competent, or is the valve tricuspid or bicuspid? Is the valve bicuspid? It usually is a connecting tissue disease, and it's nowadays more or less considered to be malpractice not to address the whole ascending aorta if you address the bicuspid valve. Only to replace the valve is considered to be malpractice. So is the aortic root dilated? Are the coronaries involved? As I mentioned, is the arch involved? So there are many different things that you need to address if you have involvement of this. But if you just have a sole ascending aneurysm that is not involving the valve, not having a dilatation of the aortic root, or no arch involvement, you can just go for the so-called supracoronary tube graft. That's a quick procedure. You don't need to address the coronaries, nothing. And it's a quick procedure with no or very low risks with this procedure. However, if you have dilatation of the root, and you believe that actually you have the aortic regurg is depending on the dilatation of the root and no pathology of the leaflets, you can go for different kind of procedure. Either you, of course, replace the aortic root with a composite graft, including the valve, either mechanical or biological valve. Or if you think that you should do a valve sparing procedure, you can go for the Jacob procedure or the David procedure. The Jacob procedure, it's mentioned here in the slide that it is a technically slightly easier procedure than the David, and I can tell everyone that this is the opposite. The David procedure is much easier, and the learning curve to do a reimplantation David procedure is much shorter than the Jacob, because the Jacob procedure, you resect the sinuses, and you have a scallop graft that you will suture to the sinuses, and and you need to be very, very careful, because it's very easy to end up with significant regurg of the aortic valve doing this procedure. And then, of course, you need to reimplant the coronaries, and that needs to be done for the David procedure as well. The David procedure, you resect everything, you keep the valve and the commissures, and you bring a Dacron tube graft down below the aortic annulus, and then you suture the commissures to the tube graft. You suspend the commissures, and this is much easier to do that in the tube graft as or compared to the scalloped Jacob procedure. This is, of course, the most recommended procedure if you have a competent aortic valve, because the prognosis for patient having the native valve is better than having a prosthesis. Also, the fact that if you in the future will have any problems with the valve, you can go for a TAVI, doing these valve sparing procedures. Yeah, what else? This is basically cerebrospinal fluid drainage is for thoracoabdominal aorta procedures. But for the aortic valve repair using the reimplantation technique with aortic annuloplasty in young patients with root dilatation and tricuspid aortic valve, that is a class 1 indication for valve sparing procedures. So yeah. What else here? To use cerebral perfusion, as I mentioned, it's a class 2A indication, even for the subclavian subclavian cannulation, and yeah. So that's it. So questions about this?
This is one.
This is yours.
They will ask you a question.
Can I?
Yeah, the same.
The same. Are there any questions? It's quiet.
Thank you, Dr. Rolf. I just want kind of your opinion regarding in the David procedure or valve sparing. There is increased mention
Yes.
in the literature about adding the ring. Adding the rings,
Adding,
the reconstruction in the aortic at the level.
you mean the annulus?
The annulus, yes.
Yeah. So what is your question actually about the annulus? If you need to say reinforce the annulus, is that what your question?
Yes.
Yeah, but yeah. No, you don't need to do anything else than you anchor the graft with plagiated interrupted sutures, and this is done. It's actually including the ring too. So the graft itself will prevent dilatation of the ring of the annulus. So you don't need to actually address the annulus specifically.
Okay, clear.
Is that an answer of your question?
Yes, yes.
Yeah, okay. Any more questions? No.
I have a question. Sorry.
Yeah.
Yeah, I'm Dr. Shabir. I'm at King Fahd Medical City, consultant cardiac surgeon. Hi. I just what is your preference? You like auxiliary? You said and giving an antegrade cerebral perfusion, retrograde cerebral perfusion. Do you, in your experience, any difference you have seen any outcome, neurological outcome between the antegrade and retrograde cerebral perfusion in your own experience?
No, actually, I have not. I have not. I believe in my hands. I believe antegrade cerebral perfusion is a little bit more complicated. You have 3 separate lines. You have these balloon catheters, and I mean, there are more steps in the procedure that makes the whole procedure more complicated. So in my hands, I am very happy with retrograde perfusion, and the key for all these kinds of procedures in circulatory arrest is to do the surgery as quick as possible, to speed up. And if you then have all these perfusion cannulas, catheters in the field, it might slow the procedure down a little bit. So I prefer to use the retrograde, but I haven't seen any difference or I mean, difference, who knows, the numbers are not that high of these kind of procedures in circulatory arrest, but I'm happy so far to continue with the retrograde perfusion technique.
Okay, thank you very much.
Thank you.
Any more question?
Thank you, Hassan.
Okay. Thank you very much, Dr. Rolf. Thank you, Hassan.
Thank you, Dr. Rolf. So the other presenter.
Professor.
Okay, thank you.
What do you say?
We cannot use the loudspeaker.